I now invite Professor Jeevan S. TITIYAL for his talk on Phaco emulsification in small pupil and implantation of premium IOLs.
Thank you, Dr. Manpreet. I just wanted to ask Dr. Ramamurthy, is there any Indian companies making these, piggyback lenses? Because otherwise, very costly.
Yeah, I've been using the IOCare lenses, no financial interest, and they have the piggyback lenses for plus minus power cylinders as well as trifocals.
Any specific calculation way to calculate the IOL power in these
It's
cases?
simply based upon what is the residual power for every diopter of positive spherical power. That is, plus 1 means it's 1.5 diopters. If it's minus power, it's 1 diopter is 1 diopter of power. That is, minus 1 is minus 1. So if I have plus 2 diopters of spherical power to be corrected, it's a plus 3 piggyback that goes in.
I think that's a very important point. I wanted people to understand these lenses are also available and the calculation can be very simple. And instead of trying to exchange the lens, which they sold, which is totally 5 rows, which is damaged, especially where people have done a large yac-slot-me, things can be very tough. If you can implant these piggyback lenses, things can be very, very simple. Thank you, Dr. Ramamurthy. I thought I'll show 1 or 2 videos because our dear friend Dr. Maligan could not come this time. So I'll show you 1 video on small pupil, how to manage these cases also. So this was 1 case. A young patient came for a toric IOL implantation and pupil was poorly dilating and had a cylinder, significant cylinder for this patient also. So this was the dilatation on the table. Normally, I am a little, egoistic person. I thought I'll not use any device and complete the entire procedure without using the device also. So in these cases, I think pre-op use of NSAID is really helpful in maintaining the pressure. So this is what I'm doing. I'm injecting the adrenaline intracamerally under the viscoelastic cover. The pupil was very rigid. The rigid pupil is normally not floppy. So you can still do a good surgery. So I'm doing a rhexis, which is slightly larger than the pupil size. I thought this will be all right. At this stage, I realized I had forgotten that this was a toric IOL implantation. Do you all understand in small pupil surgery you might be able to complete, but putting the lens in proper axis can be really challenging in this situation. So at this stage, I thought let me expand the pupil so that my surgical area will be bigger. There are 2 ways to expand the pupil at this stage. One, you can go for intracameral devices like BHEX or Beligun rings, which can expand the pupil to a desired size of 5.5 millimeter. Other thing to use iris hooks. I normally prefer iris hooks in cases where I've already initiated the surgery, where sometimes these devices can be difficult. Both can be put. And this is my technique of putting 6 iris hooks so that you have a nice expansion of pupil and making these incisions little posterior to the limbus. You can see the bleed has come. So if you're little posterior to the incision, your iris hooks will be parallel to the iris plane and it will not tend the iris so that you have less damage to your sphincter in these cases also. And that is a small tip I want to give to all young people sitting here. Make sure that you have little posterior, and these are 6 incisions. 1 is classically sub-incisional. Then I'll put all the 6 inside, then 1 by 1 slowly expand the pupil rather than just expanding to one side at one go. This is how, because this is a rigid pupil, you can tear much more. Now you can see nice 6 hexagonal appearance, re-stain the anterior capsule. You can see my rhexis was hardly 3 millimeters. So I'm trying to enlarge the rhexis. So this gives the opportunity to do the rhexis in a proper manner so that it gives you a better emulsification space for your case. So this is a microfaucet, vitreoretinal island peeling faucet I normally use for doing these procedures. Do a good hydro procedure. Rotate the nucleus because in small pupil, sometimes nucleotomy becomes easier, but removing the epicortex becomes very difficult because leave a large epicortex in these cases. So first I take out all the loose cortex, make a little trench. This is a grade 3 to grade 4 nucleus. Once you have this trench, you have now a good hold of nucleus. You can chop it better now. Rotate. See, the rotation is still not possible because I could not do a good dissection here. I'm taking out one more chunk from here. Once I've taken this chunk, the nucleus will be free now. You can see the nucleus has got free. This is called internal hydrodelineation has happened, which has separated the core from the epinucleus. Now you can one by one chop and take it out, the entire nucleus now. The learning here is little trench so that you better hold deeper and you can chop it. And this is a technique which described by our colleague Dr. Tushar. This is called a hybrid technique. So this is a Phaco handpiece inside only. Without compromising the interchamber dynamics, we just detach the aspiration tubing, attach to aspiration cannula of bimanual. So in that way, you can aspirate all around now. So I'm aspirating, this is called a hybrid technique. You can see that the rexis is still 4 millimeter. So I'm injecting the viscoelastic here. This is the Alcon toric lens, which is being implanted here. And this is a trick I normally do in some cases, especially cases with pseudo-exfoliation. This is slightly smaller rexis. I make a multiple nicks in the anterior capsule. You can see this V-shaped nicks. This will enlarge the rexis size and also decrease the phimosis if it has to happen in a post-op period also. So this is a good technique I have used in a pediatric patient, which I published long time back. This we call it a postage stamp capsulotomy. Then I remove the viscoelastic from behind. I think this is a trick which you need to know. Whenever you use the hooks or a device, you require a space to be maintained. So if you remove all the viscoelastic, later it has become very difficult to take out these hooks also. So what I'll do, I'll remove the viscoelastic from underneath the intraocular lens so that the lens can be placed accurately. I'll remove the viscoelastic from underneath. Now I'll place the lens at the desired axis. Now inject the viscoelastic over the lens. There's no viscoelastic underneath the bag here. Then comfortably remove all the hooks. Now only what you have to do is you have to remove the viscoelastic from anterior side. The lens will be stable. So this is how your lens is going to remain. If you remove the hooks before, then remove the viscoelastic, the pupil constricts and entire management of toric IOL becomes very difficult. The learning here is you always remove the viscoelastic, align the IOL under the viscoelastic, inject OBD over the IOL now, once you remove from underneath, then remove the hooks. In that way, you are at least going to damage the pupillary margin and your lens will be in the bag always. And this 6 hooks gives you a very nice orientation of a pupil. Sometimes if you only 4 hooks, then you stretch too much and that is not a good idea in these rigid pupils. Second case which I want to show you is a case with post-radial keratotomies. Many of us always debate, should we put toric IOL or not? Should we inject multifocal IOL on that? It's based on a biometry. If you see here, that it has a corneal astigmatism minus 2.3 diopters, which you can see a large degree of error is there in this particular case. It has almost 8 incisions. There it is better to map your cornea, look for aberration profile. If you see here, this is a corneal aberration profile. This is astigmatism. Trefoil, coma is very, very minimal. No trefoil, no coma. And this is very nice MTF values. And this patient, cornea is good. If cornea is good, you can always take a premium IOL as an option for these patients, and surgery can be effectively done. One of the best formula which I have realized in our post-LASIK patients, a post-RK patient, Barrett's 2K formula, which gives you a nice calculation. Always make sure your incision is little posterior. You can see, so that you don't disrupt the incision which are reaching or approaching up the limbus area. These RK incision, what we should do in the 90s, they can be 80s, it can be very, very deep, almost 90-95%. And if incision is purely corneal, that will definitely open up during your surgery here. You can see it is almost 0.5 millimeter posterior side, and my site incision is also little posterior, and that is important. And again, we will do a rexis image guided so that you have a proper rexis, because these AC depth may be little more, and your rexis size can be little altered if you even mark on the corneal side also. So this image guided system gives a nice orientation. This is a hydrodelineation and hydrodissection being done, mainly hydrodissection here. Rotate the nucleus. Though the pupil little floppy, but it's well dilated. And again here, this is my routine approach. Make a little trench so that you have a better hold of nucleus Then subsequently chop the nucleus in two halves, then make it a multiple chops, and take out the nucleus subsequently in the bag, and take out cortex aspiration, epicortical cushion and cortex aspiration very comfortably. The antechamber dynamics may be a little different in high myopic patients. Make sure you have a good IOP control if you are using active centric, or you always look your parameters will be moderate in these patients also. So once we remove the entire cortical fibers, maintain the anterior chamber, use the intraocular lens of desired calculation. This is a hydrophobic toric IOL from Technis 2 design, which is being placed in an axis of reside area. The only thing which I want to show here, surgery is simple, but again, remove the viscoelastic from all areas. Make sure you put a suture in the main wound. Don't try to hide it too much, otherwise wound gets split. So this is one teaching in a post-RK patient where incisions are very close and they're very long. Always try to suture the main wound so that you don't disrupt the wound, or even don't split the wound. That will cause induction of a new astigmatism, and things can be very difficult. So this suture can be removed after a week or 10 days, and patient visual acuity will be better. This is a day one, patient did very well, post-RK patient. So here what I talk about is doing incision little posteriorly, maybe a scleral tunnel sometimes. If you are sitting superiorly with more than 12 incision, it is better ideas. Never overfill the anterior chamber. Arc incision can open up. Suture the main incision after your surgery, which is a very important point for all of us to understand. Sometimes I have seen a post-RK patient, especially if you have more than 12 or 16 incisions, there can be, diurnal variation in a corneal profile. So it is better to see your patient before jumping on a surgery, at least in a 1 or 2 episode. That means patient coming today, I might see after 1 week or 15 days and different timings of a day. If patient come 9 o'clock, I might see patient towards the afternoon, so that I know that there is no variation in the corneal parameters. If there is a variation, that cornea is very, very weak. So sometimes that may make a huge difference in your IOL power calculation, and patient may not be happy subsequently also. I remember one of case referred to me. The patient used to have, almost emotropia in the morning time. By the end of evening, used to have a 4 diopter error in those cases because of the cornea becoming so weak. Ultimately, I had to took that patient for cross-linking subsequently. This is one case I want to show to you that things can go wrong anytime. This is a femtosecond laser. This patient has undergone trifocal toric lens in other eye. This is second I am operating under femtosecond laser assisted, very nice capsulotomy being done. The nucleus is being fragmented as per the chop pattern which was there in this particular nucleus. Remove the nucleus effectively within the bag now. The surgery becomes very simple once you have femtosecond laser, because you have a nicely oriented capsulotomy. Also, nucleus fragmentation and chop pattern, this is a Lensex platform, can be done effectively now. Aspiration of this cortex can be tough sometimes. Therefore, I am doing again, this is a hybrid technique of taking out the cortex, because once cortex are cut with the laser, sometimes aspiration difficult. Bimanual aspirations are definitely easier in these cases also. This is sub-incision can be difficult to remove. I left the fibers here. I'll be injecting trifocal toric lens in this patient, which is simply effectively going inside now. Once I've implanted, now I thought I'll do a viscoelastic removal and remove this chunk of cortex. While pulling this, I realized I've torn the capsule here. You can see this is the area of torn capsule, which is quite big. You see here, it's a very big torn thing. So I'm injecting dispersive viscoelastic underneath the IOL to tamponade this vitreous face, which I'll do from either side also. So this will retain the vitreous face in a proper position. The idea here is to, now I can't maintain this lens in the back because large tear is there on the superior side. I thought the only way better would be to have a reverse capture to be done in this patient. And this is a technique which is simpler, you can understand. If you do a bimanual technique, if you see here, I'll inject dispersive from this side and I'll take another cannula from this side, and this will lift the optics over the capsulotomy size, which is normally 4.9 millimeter for me, and maintain the haptic behind the capsulotomy. You can see this will have a square shape now, and that is the end of surgery. You can see this is square shape, this is underneath, and this is over the rexis, and almost matching my, the concerned area of dots here. So in that way, you can safeguard. So lucky I was that it happened towards the, end of my surgery. No vitreous was, prolapsed, and lens could be captured very effectively. So this is the orientation here, and actually did very well subsequently also. This is at 1 week, the picture here, nicely captured, 6/6 vision, IOLS stable in this case also. But when this patient came to me after 1 month, the patient was not very happy. She was telling me, I could see better day 1, but I'm not seeing very well after 1 month. Doctor, what is the cause? So I thought maybe some sort of inflammation would have caused, some retinal pathology. The OCT scan macula was absolutely clear, but there was induction of 0.5 diopter myopia because lens we have captured anteriorly. So there a little bit of myopic shift happens, and that needs to be explained to patient. If it would have happened before you implanted the IOL, you could have managed this, by changing the lens. But once it is inside, you have to manage like this only. Third, the last video I like to show you is a very hard cataract. Sometimes we are worried that hard cataracts, you may not achieve the good surgery, and implantation can be difficult also. So this is a technique which I have used. This is I think she was almost 85-year-old lady with a hypermature stage. Entire cortex had got, almost in a fibrosis stage, but rexis could be completed very effectively. You can see now even the hydro procedure are difficult because this is the entire cortex which has become thick fibrous mass here. And I'm going to use a technique of pre-chop here so that nucleus chopping can be easier. This is called a my loop, which I'm inserting from one side, open inside the capsular bag. So once you have a complete opening, you have to rotate your hand so that this loop gets in the central part of the nucleus. Stabilize the nucleus with your second hand, then close the loop, and this will cut the nucleus into 2 halves. You can see I'll take out now. It cuts the nucleus 2 halves. Now I rotate the nucleus 180 degrees. Again open the loop so that it goes underneath the capsular rexis margin, opens inside the bag. So in this way you can make 4 chops of the nucleus very effectively. And now I have broken the nucleus, this hard nucleus, into 4 pieces. The central backbone has been cut or broken by this my loop here. Surgery becomes very effectively simple. I'm using the dispersive viscoelastic to tamponade as well as safeguard the endothelium. Further, I can chop now. I've chopped into another 2 pieces. This 4 will become 8 chops now, and effectively I can emulsify subsequently. You can make it further smaller chops also. So this very, very hard cataract can be simply emulsified now because the central attachment has been broken. In hard cataracts, the major difficulty is difficult to break the central area. Despite making a deep trench, sometimes very difficult. Cracking becomes difficult, chopping becomes difficult. But this simple addition of using pre-chop techniques can decrease the time of emulsification, the energy, and effectively less damage to other structures of intraocular structure like corneal endothelium, wound burn, everything can be decreased now. The entire thing is taken out. There no cortex is there in this patient. Now I'm implanting the toric IOL, which will be placed at desired axis also. So you have various challenging situations which can be managed very effectively if you have the good idea of what is happening, what can happen next, and how to prevent those things, and implanting becomes simpler in these cases also. I would like to thank you all. You can go through our, this is the review article we had published in IGO, where it gives you all the intricacy of toric implantation. And any questions we'd like to answer. The panel is still sitting here. Thank you very much for a kind listening.
Sir, this pre-chop is available, it is made by which company, sir? No.
The story goes, This technique was first, described by Disa group of people.
Sir.
Arup Bhaumik, he used to call it a snare technique. And it was a totally indigenous made the wire.
Sir.
It was a platinum wire. You could just, take it inside and pull it and used to cut. Now it is commercially prepared by Jai's group of people. So
Jai's.
Jai's is manufacturing this and they supplied this. And initially, with one loop, you could do multiple surgeries. You could autoclave them also.
Sir.
Now you can do only, I think, four cuts.
Yeah.
And it costs around 10,000 rupees. So it has become commercial, which was actually, devised by one of the colleague from India only.
So it is so
In fact,
sharp.
that video got a Best of Show award in American Academy and AACRS.
So it's so sharp, it cuts such a hard, great 5 cataract.
Yeah, it cuts like a knife.
Oh,
It's
very
very
nice.
sharp cut.
Very nice, sir. Thank you.
Only thing I like to highlight here, your capsular bag has to be intact.
Sir.
Your rexus has to be intact.
Right.
And the size should be around 5 millimeter plus.
Yeah, we have to do a little larger, bigger.
If you have a very small rexus, you have a difficulty.
Right.
If you have the bag which is damaged, it's difficult. That means posterior polar cataract, you should not use it.
Right.
That's the only contraindication. Otherwise, people have used this in a subluxury cases also. You could still do it.
Right. Excellent, sir.
Yeah.
Thank you, sir. Thank you.
Sir,
Yes, please.
sir, I have a question. If you get an eccentric rexis or a larger rexis, should you continue with the toric IOL?
There is no harm if patient has a significant toric to begin with. Suppose I have a patient who has 1.5 or 2.5 cylinder. That amount of cylinder can be easily be corrected by this lens. Eccentric rexis is a challenge. I can understand. The only thing what Dr. Ramamurthy also asked this question: if you have a torn rexis, what next? We tend to forget this patient. I normally see all patients where my rexis are compromised. I put the IOL inside. Look for how this bag behaves post-operatively. Because if your bag is eccentric, one area will be covered onto the IOL surface, other area will be open. So there's a jipping phenomena happening in the post-op period, and lens can shift at that time. To avoid that phenomena, if there's fibrosis happening, there's a little bit of shift. If you do a YAG laser cuts in the anterior capsule where fibrosis is happening, the area which is covered onto the IOL surface, subsequent decentration will be avoided. The idea is to see post-op carefully, maybe after 1 month, 3 months, 6 months, 1 year, what happens with these lenses.